Myelofibrosis is a disease in which substantial progress has been made, both in understanding the disease process and the development of new treatments. New drugs are being used or being evaluated in the clinic, and many advances are on the horizon. We are so pleased to have Dr. Ronald Hoffman from the Icahn School of Medicine at Mount Sinai Hospital with us today to discuss these issues.
My name is Dr. Ronald Hoffman, and I'm a professor at the Icahn School of Medicine at Mount Sinai here in New York. And I'm very happy to speak at this 11th International MPN Patient Symposium. So what I'm going to talk about today is current management, new treatments, and drugs in the pipeline for patients with myelofibrosis. So here are my conflicts of interest. As you can see, I have research support from several biotechnology companies, which kind of goes with the landscape if you're going to be doing experimental drug therapy evaluations. So just for those of you who don't understand myelofibrosis, I'm going to give you a very brief summary of what occurs with this disorder. Obviously, it's a chronic hematologic malignancy that originates at the level of the hematopoietic stem cell, and it's a progressive disease. So patients frequently present with early forms of myelofibrosis, where they frequently have mild anemia, minimal splenomegaly, thrombocytosis, and their short-term problems are really vascular events such as thrombosis or hemorrhage. Then over a decade, these patients then go on to develop overt myelofibrosis. And again, overt myelofibrosis can also occur as a late stage of those patients who have essential thrombocythemia or polycythemia vera. So I'm going to group these groups of disorders as a single entity. And these patients can get into trouble by developing progressive constitutional symptoms, organomegaly such as splenomegaly, progressive cytopenias, and this can impact their quality of life. Over a variable period of time, these patients can then go on to develop what's called MPN blast phase, which is a secondary form of acute myeloid leukemia, that then can lead to premature death. These patients who have overt myelofibrosis can also develop low blood counts, that is anemia and thrombocytopenia, which can markedly compromise their quality of life and their overall survival. And then secondarily, due to their enlarged spleens and also due to their pro-inflammatory milieu, they can develop constitutional symptoms such as fatigue, weight loss, bone pain, and night sweats. So what is the current management of patients with myelofibrosis? First of all, we have to sort of understand what is the impact of the underlying genetic causes of these diseases, because our treatment strategies are basically dependent upon the prognosis of individual patients. As you all realize, there are 3 MPN-associated driver mutations: calreticulin, JAK2, and MPL. And you can see that those patients that have a calreticulin mutation, their median overall survival is 17.7 years, while those patients who have JAK2 mutations or MPL mutations, it's about 9 years. Most importantly, and this will come up later in this talk, is those patients who have who lack a driver mutation, who are called triple negative. Those people have a particularly poor outcome of only 3.2 years. In addition, there's an association between non-driver mutations that are high risk, such as mutations that have mutations in IDH2, EZH2, ASXL1, SRSF2, or other spliceosome mutations, and also P53. If you have greater than 2 of those mutations in the context of one of these driver mutations, then you have a really short overall predicted survival. So a number of investigators, both in Italy and also in the United States, have developed a scoring system, which is called the Mixed Molecular International Prognostic Scoring System, which basically uses a variety of parameters to predict what your overall survival would be in a particular age. And you can see that age greater than 60, hemoglobin less than 10, constitutional symptoms, platelet count less than 200,000, that triple negative phase of the disease that I discussed. If you have a JAK2 or MPL mutation, that is, if you don't have a calreticulin mutation, that's a bad risk factor. If you have the associated ASXL1 mutation or SRSF2 mutation, those are also poor prognostic parameters. So here you can see that there's a continuum to disease. And you can see if you have low risk disease, your survival is approximately 10 to 20 years. By contrast, if you have a multitude of these risk factors, you can see you're in this very high risk period and your median survival, unfortunately, is only 1.7 years. So obviously we treat patients who have low risk disease very differently from those patients that have very high risk disease. So here are the NCN guidelines for the treatment of MF based on risk and symptom score. You can see for low risk disease, primarily it's observation or JAK2 inhibitor or interferon. By contrast, if you have intermediate 2 or high risk disease or very high risk disease, most of our efforts are to get you to allogeneic hematopoietic stem cell transplantation as soon as possible. And what I'd like to show you is that's becoming an increasingly available therapeutic option. Here are a variety of agents that can be used to treat patients with myelofibrosis. For instance, we can use each of these agents for the treatment of anemia. Ruxolitinib or fedratinib, the JAK2 inhibitors, are very good at treating symptomatic splenomegaly or constitutional symptoms. Also, extramedullary hematopoiesis. Low-dose aspirin can be used to alleviate the risk of thrombosis. And unfortunately, if those patients that develop MPN blast phase, either induction chemotherapy or hypomethylating agents. There is some indication that JAK2 inhibitor therapy will improve survival to a limited extent, but overall, the only curative approach we have is allogeneic stem cell transplantation. So what are our options for patients who have low risk disease? Usually we observe those patients, but there's some suggestion that pegylated interferon might be a useful agent. And this is based upon a study from France, where they had basically 62 patients with various phases of myelofibrosis, predominantly low-risk disease. And you can see that there are 17 patients who remained on this drug for over 73 months. By contrast, there are 45 patients who had to either get other therapies, allogeneic stem cell transplantation, or ruxolitinib. And you can see that those patients that had to discontinue their therapy, they had a limited survival, while those patients who received pegylated interferon, presumably those are patients who had low risk disease, they had a more prolonged survival. One must remember, if you recall from the MIPS, that those patients had a median survival of 20 years. So obviously we're going to need a long-term study to determine whether this intervention actually makes a significant difference in the outcome of those patients. And this kind of information is basically pictorially represented on these various groups. And you can see that those patients who had low risk disease had a median survival that had not been reached. How about if you have more symptomatic or more overt forms of myelofibrosis? The standard of treatment right now is ruxolitinib or fedratinib therapy. I'm just going to show you the ruxolitinib therapy, and this all is well known to you. You can see that these are patients who had symptoms. You can see that those patients who received ruxolitinib had a marked improvement in their symptom score. And also you can see on this plot that those patients compared to placebo-treated patients had a marked reduction in splenomegaly. And so that's what this drug does. Basically, it improves symptoms and it decreases spleen size, and it has some improvement. It is associated with some improvement in survival, but unfortunately, patients inevitably progress. So tips for using ruxolitinib: it's indicated for splenomegaly or MF-related symptoms. Starting dose is based on platelet number because this drug, but starting dose is not, anemia is not a contraindication and does not affect the benefits of ruxolitinib. It should be, one should avoid prophylactic underdosing, maintain the maximum tolerated dose to achieve larger reductions of splenomegaly, and avoid abrupt interruption of ruxolitinib therapy or fedratinib in patients responding well, because these patients can develop a cytokine storm syndrome, and they can be covered during this prednisone, with prednisone during this interruption phase. How well you do with ruxolitinib therapy is really determined by your mutational profile. And in the left panel, you can see that those patients in the orange curve who had greater than one of these high-risk mutations did much less well than those patients who did not have these mutations. And similarly, you can see that those patients, in addition to their driver mutation, who had greater than 3 mutations, also did well. So it's really based upon your mutational profile, how well you're going to do for the drugs. Patients with symptomatic anemia and myelofibrosis, basically one of the easiest ways to treat these patients is with erythropoiesis stimulating agents, and this is based upon a variety of studies. And you can see the agents that can be used are danazol, prednisone, or thalidomide in those patients that don't respond to erythropoiesis stimulating agents. Those patients who have a high erythropoietin level at baseline are less prone to response. Here you can see in this study, you can see that the duration of anemia response can be quite prolonged over months. And here you can also see that patients following ruxolitinib, which can be considered a type of chemotherapy in this setting, can also have a response, while those patients who have profound anemia prior to ruxolitinib also have that ability to respond. Again, just to emphasize, allogeneic stem cell transplantation is curative for more overt forms of therapy, and all of our prognostication is really to define those patients who should go for transplant. This is a study that we did in our MPN consortium, and here you can see in the top panel the median survival for those patients who had a HLA-matched sibling donor. It has not been reached. So we're anticipating that those individuals in about 70% of patients, 70% of instances would actually be cured of the disease. By contrast, at least when this study was done in 2014, those patients in the lower panels who did not have a matched donor but had an unrelated donor or a mismatched donor, their survival was about 30%. Allogeneic stem cell transplantation is now an option for greater numbers of patients with myelofibrosis. And this is probably best shown by this very seminal paper from Dr. Bacigalupo in Genoa at that time. He's now in Rome. And here you can show from the years 2010 to 2014 in this right panel that those patients who had alternative donors, and what we're really talking about here is haploidentical transplants, those haploidentical siblings that only have a half match are actually doing as good as those patients who had alternative donors. So what we're doing now at Mount Sinai is in those patients that don't have HLA matched donors, those patients we're treating with haploidentical transplantation with some very promising results. Frequently, it's been thought that patients with MPN blast phase are basically not treatable by allogeneic transplantation, stem cell transplantation. And this is a study from Europe, from a bone marrow transplant registry. And you can see that these are patients who were transplanted in the chronic phase, and these are patients that were transplanted in the dotted line. In the blast phase, you can see that the survival is inferior. So it's best to transplant patients prior to blastic transformation. However, you can see here at Sinai, in the 12 patients who we treated with MPN blast phase, after giving them either hypomethylating agents or induction therapy and getting them back into reasonable shape, you can see that the 2-year overall survival is approximately 42%. So that's really our approach for those unfortunate patients that have MPN blast phase, to give them a sort of induction or hypomethylating agent and then take them very quickly to transplant, hopefully with a matched sibling donor, or if they don't have a matched sibling donor, then with a haploidentical donor. Now, how about older patients? Because patients who have myelofibrosis frequently are over age 60. Here you can see a study from Europe, again, published just in 2019. And these are patients over 65 years age. The median age was approximately 67. And you can see, using present day conditioning regimens, you can see that those patients do remarkably well. So right now we're transplanting patients up to 70 years of age. Most important is this is a score of fitness, the patient's fitness. You can see that those patients that don't have distressing comorbidities do much better than those patients that have other comorbidities. So patient selection is very important, but patients above 60 years of age are still, allogeneic stem cell transplantation is still an option. Importantly, there are now new treatments for patients with myelofibrosis, more overt forms of myelofibrosis, and I'd like to go over 2 of those. Well, one right now is basically combination therapy with pegylated interferon and ruxolitinib, and that's ongoing therapy that has been now being evaluated both in PV and ET. This is a study from Scandinavia, and this is essentially those patients that have early forms of myelofibrosis. And you can see this is in months after a year. You can see in those patients, 10 out of the 18 patients had complete hematologic remission. Importantly, you can see that many of the patients using the JAK2 V617 of allele burden as a biomarker, you can see that over time, over this year where they received both ruxolitinib and pegylated interferon in combination, you can see that there was a reduction in the JAK2 V617F allele burden. The downside of this pegylated interferon ruxolitinib combination is that approximately 20 to 30% dropped out due to adverse effects. So this is a promising type of combination therapy that needs to be evaluated very carefully in those patients who are not responsive to interferon. So additional drugs that are now in the pipeline for patients with myelofibrosis, I'm going to go over 2 of these drugs. One targets NF-kappa B activation. NF-kappa B is a transcription factor that essentially leads to the pro-inflammatory milieu that causes the systemic symptoms that occurs in patients with myelofibrosis. and also activates the marrow microenvironment that promotes stem cell predominance of the malignant stem cells. And this is beautiful work that was done by Stephen O's lab at Washington University. And here you can see that he's using mass cytometry, which is a very very sensitive and sophisticated approach to show that patients with myelofibrosis, in comparison to normal bone marrow, have activation of NF-kappa B. Well, we now have drugs that can target NF-kappa B, and those drugs are called bromodomain inhibitors. And BET proteins bind to acetylated lysine residues on DNA, and they lead to activation of genes. And one of those genes is NF-kappa B, which is the master regulator of cytokine regulation. And you can see that this drug, or the BET inhibitors, generally decrease the elaboration of these pro-inflammatory cytokines in megakaryocytes and also in monocytes that lead to systemic symptoms and transformation of the pro-inflammatory milieu. So this concept has been evaluated in a clinical trial that is extremely promising. This is a paper that I presented a year or so ago prior to the pandemic at the European Hematology Association, and it evaluates a drug called CPI-610, which is a bromodomain inhibitor, which reduces pro-inflammatory cytokines, bone marrow fibrosis, and the number of transfusions in patients with overt myelofibrosis. So again, CPI-610 is a potential best-in-class bromodomain inhibitor, and it's basically a largely non-toxic drug. It targets only BET family inhibitors, and it has similar potency for all the tandem bromodomains. So here's the trial, which is very complex. The trial involves patients that are refractory or intolerant or ineligible for Rux therapy, also patients that were added on to Rux therapy, and those patients who had not seen prior JAK2 inhibitor therapy and therefore are treated in combination with JAK2 inhibitor and bromodomain inhibitor CPI-610 at onset. The bottom line is that the patients that were treated were very high-risk patients. You can see that many of them had greater than 3 mutations. Many of them had seen prior Rux therapy. They were anemic. They had large spleens, and they had a high symptom score. And when you see also their mutational patterns, you can see that the large majority of them had ASXL mutations and also had high-risk mutations. So one would think that they would do poorly with any kind of therapeutic intervention. The beautiful part of this study is that the patients actually responded. And here you can see that 14 of 16 patients at that time had remarkable reductions in spleen volumes. They had improvement in systemic symptoms. And you can see in these 2 patients, this is their clinical course, and the red arrows indicates transfusions. You can see after institution of this therapy that these 2 patients no longer required no longer required red cell transfusions. I should tell you that one cycle of this therapy is approximately 21 days. The nice part about this drug is it's an oral drug, and as you can see, here's the serious adverse effects, all grades, that basically in combination and alone, no grade 3 serious adverse effects were observed with monotherapy, and only 4 of the 44 patients showed greater than grade 3 platelet count decreases or thrombocythemia, which was reversible. Another drug that's very promising, at least from my point, is a drug that you've heard about before. It's called imetelstat, and this is a paper that was presented by John Mascarenhas, my colleague at ASH in 2018. Imetelstat, as you recall, is an inhibitor of telomerase, and in this study, which included over 100 patients, again, intermediate high risk patients were treated. These patients relapsed or were refractory to JAK2 inhibitors, and patients had to have worsening of splenomegaly, no reduction in spleen size or spleen size after 12 weeks of JAK2 inhibitor therapy, or worsening splenomegaly, active symptoms of myelofibrosis, and measurable splenomegaly. In this trial, the co-primary endpoints at week 24, this is an intravenous medication, was reduction of spleen size and symptom response, and most importantly, safety. The key secondary endpoints were safety and overall survival. And you can see that patients who were treated with 2 doses, either 9.4 milligrams per kilogram every 3 weeks, that's 1 injection, or a lower dose of 4.7 milligrams per kilogram at 3 weeks. And an interim analysis was done after 20 patients in each arm. And the lower dose was closed. Eventually, you'll see after 48 patients were accrued, and you'll see why. So you can see that in this is the 2 patient groups. So it's the 4.7 milligrams had far less effect on spleen size. And you can see those patients that received the 9.4 milligrams had a much more dramatic effect on spleen size, and also had a much more dramatic effect on symptoms. So the higher dose really was much more effective. So this 4.7 milligram group, you can see, served almost as a control for this patient population. So most importantly, what we're really interested in is patients living longer. So here you can see that those patients that got the higher dose lived longer than those patients that got the lower dose. You can see that their median survival was 29.9 months in comparison to the 19.9 months that patients who received the 4.7 milligrams per kilogram. Now, if you recall, in one of the initial slides, those patients that had triple negative disease, that is, they lacked a driver mutation, those patients did extremely poorly. And here you can see on this right diagram, this right figure, that those patients who had triple negative disease and received 9.4 milligrams per kilogram of imetelstat, their survival, their median survival in months had really not been reached at the time of this presentation, while those patients who didn't have triple negative disease, they had a median survival of 24.6 months. So these patients who received the high doses of imetelstat essentially lived longer, even though they were in an extremely high risk group, including those patients who had triple negative disease, which we really don't have effective drug therapy. So my conclusions about the present treatment of myelofibrosis are increasingly optimistic. Unfortunately, there are limited therapeutic options for patients who do not respond to frontline therapy, which is really Ruxolitinib. In medically fit patients up to age 70 who have an appropriate stem cell donor, that includes haploidentical donors, one should seriously consider allogeneic stem cell transplantation. And there are a growing number of drugs. I've just mentioned two of them, imetelstat and also CPI-610, that are active drugs that are in the pipeline and hopefully will be given serious consideration for approval by the Federal Drug Administration. And I'd like to encourage, and I know how difficult it is, especially during the pandemic, that one would consider participation in clinical trials, because that's the only way we're going to be make progress in this area. So I'd like to thank you for your attention and would be happy to answer any questions during the question period. Thank you.
Essential thrombocythemia is a disease of too many platelets, and it still remains a troublesome illness. Dr. Ellen Ritchie will discuss our approach to treating this disease.
Hello, my name is Dr. Ellen Ritchie, and I'm an associate professor of clinical medicine at Weill Cornell Medical College, and I'm here to talk to you today about current management of essential thrombocythemia. So essential thrombocythemia is a rare disease, and it's even called one of the more indolent of the myeloproliferative diseases. It can be complicated by severe vascular events, including thrombosis and bleeding, and these can be life-threatening. So it's a very serious outcome of this disease. But it may move a little more slowly or behave a little bit more differently than PV or primary myelofibrosis. The estimated incidence in the United States is 2.5 cases per 100,000, and the prevalence is approximately 24 cases per 100,000. Women are more affected than men with an approximate ratio of 2 to 1. So if you live in a small community, it's likely that you may never meet another person who has essential thrombocythemia unless you do so online. Many doctors who treat these diseases don't see a lot in their practice. If you are in a small town, you may only see one or two during your entire career. So it's a rare disease that not many people have, and this makes it more challenging for a patient to seek out the best care. Evidence suggests that ET is a more indolent disease than PV or MF. The median age of diagnosis is around 60 years, but 20% of patients are younger than 40 years. But the expected survival is 19.8 years compared to 13.5 in PV and 5.9 years in primary myelofibrosis. And the cumulative incidence of blast transformation is lower in ET, 3.8%, than in PV, which is 6.8%, or primary myelofibrosis, which is 14.2%. So it's because of that expected survival and the lower incidence of blast transformation that this is referred to as a more indolent disease. But it's important to note that the outcome of this disease, which could be big thrombosis or bleeding, can be very severe and life-threatening, just as it can in other myeloproliferative diseases. 90% of ET patients have mutations in either JAK2, CALR, or MPL. 10% of patients have triple-negative disease. So the majority of patients have somatic mutations who are diagnosed with essential thrombocythemia. The identification of these mutations has really improved the diagnostic approach to all MPNs and has improved our ability to treat these patients. And these mutations are typically mutually exclusive in ET patients. You don't really see patients who are positive with JAK2 and CALR or MPL and JAK2 at the same time. The 2016 WHO criteria for ET requires either 4 major criteria or 3 major criteria and 1 minor criteria. And the major criteria include an elevated platelet count over time of greater than 450, the presence of characteristic bone marrow findings, including a lot of early platelets with increased numbers of very large, very mature-looking early platelets who have many lobulations in their nuclei. Many of them are clustered together, and this is not something that we see in a normal bone marrow. A patient cannot meet criteria for a BCR-ABL positive disease, which is CML, polycythemia vera, primary myelofibrosis, myelodysplastic syndrome, or any other myeloid neoplasms. And the fourth major criteria is the presence of one of these mutations, JAK2, CALR, or a MPL mutation. The minor criteria include the presence of a clonal marker, which means a mutation that we might see in myeloid disease, but it's not a JAK2, CALR, or MPL mutation, or the absence of any other cause of a reactive thrombosis, such as iron deficiency or infection. So our approach to the differential diagnosis of essential thrombocythemia looks something like this. Usually patients are referred because they've had a couple of platelet counts which are over 450, and they're referred to a hematologist, where when you see the hematologist, the CBC is done and an iron panel. Someone looks at your blood under the microscope to see whether or not it's what findings we may see that would be associated potentially with many diseases. We do testing for BCR-ABL, JAK2, CALR, and MPL mutations, and we see what those results show. If you have iron deficiency, that's a common cause of an elevated platelet count. So iron deficiency, if that's your problem, allows us to say that you have a reactive thrombocytosis, and that if you replete your iron, your platelet count will probably go back to normal. We also look to see whether you have an inflammatory state. Do you have a history of infections? Do you have a metabolic syndrome? Do you have other things which may be driving a higher platelet count? And we do this by doing a careful medical history and potentially some additional testing that is not described here. If you're JAK2, CALR, or MPL mutated, a diagnosis of essential thrombocythemia is likely, but a bone marrow biopsy is required for confirmation. Because without a bone marrow biopsy, we can't necessarily differentiate your disease from primary myelofibrosis or even from polycythemia vera. So it's very, very important, if you have one of these gene mutations, that we are able to do a bone marrow biopsy to actually confirm your disease, to make sure that that's the disease that you have. In the absence of JAK2, CALR, or MPL mutations, we suspect triple negative disease, but we also need to do a bone marrow biopsy to tease out that result, to do some other genetic testing, and a careful history for hereditary causes of thrombocytosis or non-clonal diseases that may be associated with a high platelet count. So when you see the hematologist, they should spend some time doing a complete medical history to rule out all other conditions that can be associated with thrombocythemia and to evaluate your comorbidities and your cardiovascular risk factors. They'll ask you a detailed family history to identify family members with thrombocytosis or other hematologic malignancies to make sure that you don't have a hereditary cause of thrombocytosis, which would lead down a different pathway for testing and diagnosis. We ask about lifestyle habits, smoking, exercise and dietary habits, in order to identify cardiovascular risk factors. We ask about symptoms, including headaches, vertigo, dizziness, rash, itching, body aches, concentration or mood difficulties, weight loss, fever, chills, or sweating. All of these things can be associated with a diagnosis of essential thrombocythemia, and some of these may really interfere with quality of life. We do a careful physical exam, carefully to note whether or not you have an enlarged liver or spleen, which can be associated with these diseases. And we look carefully at your medications, your regular and recent use of drugs. So we would be able to identify any medications that may react with anything that we may decide to give you. Initial tests include a CBC and iron panel, a CRP to look at your inflammatory state, screening for BCR-ABL gene rearrangement, and testing for JAK2, CALR, and MPL mutations. Depending on what these initial tests show, you may be required to have a bone marrow aspiration and biopsy to make a full diagnosis. And for platelet counts over 1 million, von Willebrand factor testing might be necessary to evaluate your risk of bleeding. Patients who are at risk of bleeding are not patients that we want to put on aspirin. And those are patients that may require lowering of their platelet count in order to decrease their bleeding risk. Sometimes body habitus does not allow us to get a good examination to determine the size of your spleen and liver. So an abdominal ultrasound also may be necessary. When we think about prognosis of essential thrombocythemia, we're really worried about the risk of thrombosis. And when we're treating ET patients, we really are trying to decrease that risk of thrombosis. So there are scoring systems, such as the IPSET thrombosis score, that helps us predict the yearly risk of thrombosis in patients diagnosed with ET. We look at clinical characteristics, age, whether or not there's been a prior thrombotic event, and cardiovascular risk factors. You're assigned points for every aspect of these clinical characteristics, and based on your total number, you're categorized as low risk, intermediate risk, and high risk. And this can help us to guide treatment to try and decrease risk of thrombosis. There are other factors that we consider in prognosis. For example, transformation to AML is a concern in the back of all of our minds, and transformation to myelofibrosis. These are rare but significant causes of morbidity and mortality in ET patients. When ET is confirmed based on a bone marrow biopsy morphology, the risk of leukemic transformation is estimated to be quite small, 0.7% at 10 years. But 2.1% at 15 years. And multiple risk factors have been identified for progression, including anemia, platelet counts over 1 million, increased age, high white count, previous blood clots, and whether or not there's reticulin in your bone marrow and how cellular your bone marrow may happen to be. Myelofibrosis is a more common complication of ET than AML. Large cohort study probability of myeloid disease transformation found that 3.8% at 10 years, 19.9% at 20 years, and 29.9% at 30 years was the occurrence rate of myelofibrosis in ET patients. The median time to development of myelofibrosis was 12.4 years. So we're worried in the back of our minds about progression of disease. Our goals of treatment really in the short term are to minimize the risk of thrombosis and bleeding, to decrease the risk of transformation to MF and AML, although we don't really have specific therapies that will decrease the risk of developing AML in ET patients. We like to decrease the symptom burden and the effect on quality of life. And it's interesting that there are studies showing that there's substantial evidence that ET can be associated with a decrease in quality of life, even in patients with low-risk disease. And as many as 40% of low-risk patients actually report moderate to severe symptoms of their disease. And these include things like fatigue, early satiety, just general, malaise and inactivity, concentration and mood issues, abdominal discomfort. And based on how severe patients' symptoms are, this may drive our plan to treat you. We may intervene earlier with cytoreductive therapy. The NCCN and ELN both have guidelines for risk stratification and for treatment based on that risk stratification in patients with essential thrombocythemia. Again, looking at many of the same characteristics that we saw earlier in the IPSET scoring system. Age, whether or not you've had a past thrombosis, and they also look at cardiovascular risk management. So in very low risk and low risk disease, you're under 60. In very low risk disease, you have had no history of thrombosis, and you are JAK2 negative. So these patients fall into a low risk category, and you may not need to treat them at all unless they have cardiovascular risk factors, and then you may decide to treat it with low dose aspirin. Low risk disease, and it's also under 60, no real history of thrombosis, but JAK2 positive disease. These patients have a slightly higher risk of thrombosis or higher rate of thrombosis, and low-dose aspirin may be indicated in these patients. In intermediate risk disease, they're over 60, no history of thrombosis and JAK2 negative. But these patients also have a higher risk of thrombosis, and aspirin is usually initiated in these patients at low dose. But over the age of 60 or prior thrombosis or JAK2 positive, it would be necessary to intervene with cytoreductive therapy and low-dose aspirin, depending upon platelet count. Again, if the platelet count is well over 1 million, we would check to make sure that you didn't have acquired von Willebrand syndrome that would allow you to bleed more easily than to clot. The ELN guidelines do not have a very low risk category. They divide patients into low risk, intermediate, and high risk. Again, low-dose aspirin is mainly indicated for in low-risk disease for cardiovascular risk factor management or in JAK2 positive disease. In intermediate risk, the same, but all high-risk patients would require cytoreductive therapy. Antiplatelet therapy is really aspirin patients and aspirin therapy in ET patients. And the use of aspirin in ET patients is extrapolated from studies looking at the use of low-dose aspirin in polycythemia vera patients, where it was definitely important in decreasing the risk of thrombosis. Recent data from ET studies suggests that not all ET patients need to be treated with aspirin. In low-risk CALR mutated patients, low-dose aspirin treatment increased the risk of bleeding without reducing the risk of thrombosis. So we generally don't use in very low-risk patients with CALR mutations aspirin. It may not be necessary. Cardiovascular risk and mutational status need to be considered together with risk factors for bleeding and determining the need for antiplatelet therapy. So patients with an acquired von Willebrand syndrome really are not good candidates for aspirin therapy. JAK2 positive patients may be better candidates than CALR mutated patients because they have a higher risk of thrombosis. And patients with uncontrolled cardiovascular risk factors who happen to have ET may also be patients that would require more aggressive treatment. Patients with elevated platelet counts over 1.5 million really need to be checked for von Willebrand's disease that has been acquired, and they are at increased risk of bleeding. And patients with elevated counts over 1 million need, again, evaluation, at least for acquired von Willebrand's disease before the initiation of aspirin if a hematologist is thinking of doing that. The most common therapy that's used in ET patients is really hydroxyurea therapy, and this therapy has been around for a long time. And unlike in the other diseases such as polycythemia vera, there is clinical trial data to support the use of hydroxyurea in the treatment of high-risk ET patients. There was a study where they actually randomized 114 patients to hydroxyurea versus no myelosuppressive therapy and found lower thrombosis rates in the hydroxyurea arm. There was another study looking at 809 patients taking low-dose aspirin randomized to either hydroxyurea or anagrelide. And the hydroxyurea arm had a lower composite endpoint of arterial and venous thrombosis, or death from thrombosis or hemorrhage. And these findings were observed despite similar platelet counts. And so this is another study really in favor of hydroxyurea as a frontline therapy. There is absolutely no evidence that hydroxyurea can prevent transformation to myelofibrosis or AML over time. The drug does not target the mutant clone and will not modify the natural history of the disease. And it's important to realize that hydroxyurea does have significant toxicities. In younger patients, we worry about teratogenic complications. And we have to be very cautious using these drugs in patients during their childbearing years. There can be GI toxicities to the drug, such as nausea or anorexia. When giving you a dose that will actually control your platelets may also give you a low white blood cell count or a low hemoglobin and hematocrit. And it can be difficult to manage hydroxyurea to manage your complete blood count. And there's always an infection risk if you are using hydroxyurea to the point that your white count becomes very, very low. Cutaneous toxicities are also common in hydroxyurea treated patients, and there's a recent paper suggesting that they're really much more significant than we have been giving them credit for. The German MPN study group actually looked at 172 patients treated with hydroxyurea who had PV, ET, or MF. 92 patients were studied retrospectively and 213 in a prospective cohort. And 150 of these patients were on hydroxyurea. In the retrospective cohort, there were 50 cutaneous adverse events, and nearly all of them were from hydroxyurea treatment. And this was at a median treatment time of 3.4 years. And 31% of patients in the retrospective cohort actually discontinued the drug because of cutaneous toxicity. In the prospective cohort, 65 cutaneous adverse events were seen, and 60 of those 65 occurred while on hydroxyurea treatment. And the most frequently reported toxicities were ulcers, skin rashes, squamous cell carcinoma, and basal cell carcinomas. This was at a median daily hydroxyurea dose of 1,000 milligrams a day. So there's a statistically higher incidence of cutaneous adverse events in patients who are treated with hydroxyurea. And given that the incidence is twice as high in the prospective cohort, hydroxyurea skin toxicities may be really underdiagnosed. Another upfront choice for treating patients who need cytoreductive therapy who have essential thrombocythemia is pegylated interferon alpha-2. This has been shown to induce sustained complete molecular response in a subset of patients with JAK2 positive ET. And positive effects have been seen on CALR mutated patients where there were high rates of hematologic and molecular responses that in some cases were maintained even after discontinuation of the drug. There was a recent study called the PROUD-PV study, which was a randomized phase 3 trial of a rogue PEG interferon, which is not yet approved in the United States, but it is a long-acting interferon, versus best available treatment. 97% of those patients were on hydroxyurea. And it enrolled early-stage polycythemia vera patients. The trial failed to demonstrate non-inferiority of rogue interferon to hydroxyurea at 12 months for a composite endpoint of a complete hematologic response and spleen size normalization. But the response rates continued to improve over time. And both the composite outcome of complete hematologic response and symptom improvement, as well as complete hematologic response alone, were superior to hydroxyurea at 36 months. These results may extrapolate to ET patients. We'll have to look at studies ongoing to determine the value in ET patients. But it really opens our eyes to the idea that treating patients with myeloproliferative diseases earlier with interferon may have a positive effect. There was an ET meta-analysis looking at responses to interferon, and the overall response rate was 80.6% for all studies combined. There were 30 studies. The complete hematologic response and CR rate was 59%, and the partial hematologic response PR rate was 35.8%. The rate of thromboembolic complications was 1.2% per year, suggesting that interferon is really an important upfront therapy that can be used to treat patients with essential thrombocythemia. The side effects of interferon treatment, seem like a very long list. A flu-like syndrome, fatigue, nausea, an exacerbation of psychiatric disease, the development of depression or anxiety, an increase in LFTs, the development of autoimmune diseases, potential retinal disease, thyroid disease. And previous studies that done by Dr. Kalajian shows that there was a very high discontinuation rate based on these types of symptoms. But a recent meta-analysis, showed that the discontinuation rate was actually lower at 8.8%. And that The doses that need to be used of interferon to treat ET patients may not be that high, and the lower doses of interferon may have a better side effect profile. That being said, patients on interferon are monitored carefully for any of these side effects and the development of potentially fatal side effects such as psychiatric disease causing severe depression and suicidal ideation. Anagrelide is listed by ELN guidelines as really a second-line therapy for the treatment of essential thrombocythemia. It selectively decreases the platelet count, but it's used infrequently, mainly because of conflicting results from clinical trial data and the potential this drug may have for cardiovascular toxicity in patients who are already at cardiovascular risk. The anhydrate trial, the anagrelide versus hydroxyurea trial, showed anagrelide was non-inferior to hydroxyurea in preventing vascular events. But the second trial, which I had mentioned earlier, where hydroxyurea plus low-dose aspirin was compared with anagrelide plus low-dose aspirin in high-risk ET patients, showed that hydroxyurea plus aspirin was superior in preventing thrombotic complications. And then on the anagrelide-treated arm, there were higher incidences of arterial thromboses, bleeding complications, and fibrotic progression. Non-controlled studies have suggested that patients receiving anagrelide experience anemia, cardiac complications, including arrhythmia and cardiomyopathy, and renal insufficiency at higher rates. This is currently recommended as a possible first-line therapy in NCCN guidelines and second-line therapy in ELN guidelines. And as I said, most practitioners use this with a little caution because of our concern about cardiovascular risk. Ruxolitinib, which is a JAK2 inhibitor, is approved for the treatment of myelofibrosis and for polycythemia vera. And what about its efficacy in treatment of essential thrombocythemia? There was an open label phase 2 randomized controlled clinical trial looking at ruxolitinib, the JAK2 inhibitor, versus best available therapy in essential thrombocythemia in PV patients resistant or intolerant to hydroxyurea. In the ET patients, there were 58 patients treated with ruxolitinib versus 52 with best supportive care. And there was no evidence of improvement in the complete response rate within a year reported in the 27 of 58 Rux patients compared with 23 out of 52 BAT patients. There was no difference between the two groups. At 2 years, the rates of thrombosis, hemorrhage, and transformation were not significantly different between the two arms. The only difference between the two arms were that some of the disease-related symptoms improved in patients receiving ruxolitinib therapy versus best available therapy. So for symptom management, there may be a role for ruxolitinib in the treatment of ET patients. Molecular responses were few, 2 complete molecular responses and 1 partial molecular response in CALR patients. But there was 1 transformation to AML that occurred in one of the complete molecular response patients, which leads us to wonder, what the value of a complete molecular response actually is in these ET patients. Grade 3 and 4 anemia occurred in 19% of the Rux-treated patients as opposed to 0% to the best available therapy patients. And grade 3 and 4 thrombocytopenia occurred in 6.9% of the Rux patients versus 0% to the best available therapy patients. So ruxolitinib is not superior to current second-line treatments in essential thrombocythemia. And if there is a role for this drug, it would be only to control symptoms that are not controlled by other drugs which are available to treat this disease. So this is a summary of the therapeutic options for ET patients who require cytoreductive therapy. And those are patients with high-risk disease, patients with prior thromboses, over 60, patients who are JAK2 positive with prior thromboses. The frontline therapies really are hydroxyurea versus pegylated interferon. And there's intriguing data that using pegylated interferon earlier on in the disease course may be a wise choice. We'll have to wait for full data to know. In patients in childbearing years, hydroxyurea can be teratogenic if you become pregnant. So pegylated interferon may be a better drug to think of in that patient population. It's important to think of both of these drugs and to realize, to look at the patient in front of you and see what the best therapy might be. Patients with a long history of skin cancer or many skin cancers may not be the best for a hydroxyurea therapy. Patients who have severe depression may not be good candidates for pegylated interferon. So it's important to look at the patient in front of you and determine whether or not either of these drugs are a good fit. Antiplatelet agents should be used in any patient with ET who has extensive cardiovascular risk factors. Certainly should not be used in patients who are CALR positive with very low risk or low risk disease if there's no cardiovascular reason to treat them. Antiplatelet agents definitely play a role in the treatment of intermediate and high-risk disease patients with ET. It's important, however, in patients with very high platelet counts to make sure that you're not having acquired von Willebrand's disease and are at higher risk of bleeding. These patients are not good candidates for antiplatelet agents. Second-line therapies include anagrelide, ruxolitinib, other antiplatelet agents if they're refractory or have developed thromboses on aspirin. In older patients, it may be that with difficult to control disease, busulfan can be a drug that's used. I didn't really talk about it in my presentation because we use it very infrequently, usually in very older patients who are unable to use hydroxyurea and are not good candidates for interferon or anagrelide. Anticoagulation may be necessary in patients with splanchnic vein thromboses or in patients with refractory thromboses. And clinical trials are now being run in primary myelofibrosis of some new agents, including BET inhibitors and a drug called navitoclax. Both of these drugs may actually be useful in the treatment of essential thrombocythemia. There is a BET inhibitor trial which will be opening for ET patients, and navitoclax may also be a drug that will be filtered down to the ET patients after myelofibrosis studies have been completed. It's exciting that there are new agents that are out there on the horizon that may be able to improve the course of this disease. Thank you for your attention to this presentation, and I'll be excited to answer any of your questions.
Thrombosis, as everyone in this audience knows, means clotting. Thrombosis and other vascular and bleeding complications remain a problem in the MPNs. Dr. Andrew Schafer will now discuss new findings and recent progress.
So I'm very pleased to be here today to talk to you about this topic, which has been frankly less emphasized in the past whenever we discuss the MPNs. And I think this is because some have viewed thrombosis and bleeding as only unfortunate complications of the MPNs rather than actual manifestations of disease progression. So this is certainly understandable. After all, it's the progression of disease that most patients are most focused on, as they should be. However, it's important to note that the concept is beginning to change as we are now learning that clotting problems in the MPNs are in fact intimately and inextricably linked to their pathobiology and outcomes. So regardless of how you view it, the magnitude of the problems of thrombosis, vascular complications, and bleeding, which I'll be talking about, is really undeniable. So here's one of several comparable published outcomes data since this was published, in this case relating only to P-Vera patients in a cohort of over 1,600 PV patients. The main cause of death was thrombosis or bleeding, which occurred in 45%. It was mostly thrombosis, actually. Hematologic transformation was responsible for only 13% of the deaths, and 42% of the others who died of a miscellaneous list of other causes. So I think it's now well established that thrombosis, vascular complications, and to a lesser extent bleeding are simply the most common causes of morbidity and mortality in the MPNs. So let's begin with some important clinical observations regarding this. This is a slide from Dr. Tiziano Barbui from Italy, who presented this at our first international symposium of thrombosis and MPN experts in Charleston, South Carolina last summer. But this shows the prevalence of arterial and venous thrombosis at presentation when MPN was actually diagnosed and within the 3 years before the MPN diagnosis. And as you can see, for ET patients, 20% of them had thrombosis, 14% arterial, 6% venous. For PV patients, 23% had thrombosis at the time of diagnosis or in the previous 3 years, 16% arterial, 7% venous, and for myelofibrosis, a total of 9%, with 4% being arterial and 5% being venous. Now, I think it's very important to distinguish. By the way, this study, which I just showed by Barbui, has been confirmed by several others that the thrombotic complications in MPNs tend to occur very early after or even just before the diagnosis of MPN, and they are much less common later in the course. Presumably this is because those patients are now being treated and under relatively good control. So it's really important to know, I think, that there are basic differences between venous thrombosis and arterial thrombosis. The arterial circulation, as you know, pumps well-oxygenated blood from the left side of the heart to all parts of the body, where they feed oxygen to tissues and then return in a deoxygenated form of red cells in the venous system back to the right side of the heart and into the lungs for renewed oxygenation. Now, there are some very fundamental differences to keep in mind about how arterial thrombosis and venous thrombosis actually occur. In both arteries and veins, the inner aspect of the blood vessel wall, shown here as if transected, is lined by this monolayer of so-called endothelial cells. It also occurs in venous vessels, as you can see here, as well as microvessels, which actually join the veins and arteries. The big difference is that the arterial circulation is under greater pressure, under greater shear stresses, and most importantly, it is where atherosclerosis takes place. And we know that arterial thrombosis in anyone, including MPN patients, occurs almost exclusively, not completely, in individuals who have underlying atherosclerotic disease, where there is atherosclerotic plaque formation, which is filled with lipid, cholesterol, and when these plaques rupture, they suddenly form this clot, which is mostly made up of platelets, which eventually can occlude the entire artery. So this is on the substrate of underlying atherosclerosis, and total occlusion, of course, would lead to the events of myocardial infarction with coronary arteries or stroke with cerebrovascular arteries. In contrast, there is no atherosclerosis in the inner lining of veins. And so venous thrombosis occurs by the composition of mostly fibrin, not so much platelets, that's caused by stagnation of blood flow, especially in the dependent parts of the body, and intrinsically increased coagulability of blood in certain conditions, including the MPNs. Now let's look at the kinds of thrombosis and vascular complications that occur in the MPNs. On the venous side, they're most commonly the ones that we see in non-MPN patients, deep vein thrombosis and pulmonary embolism. But in MPN patients, there is an unusual propensity to develop venous clots in the veins of the abdomen, intra-abdominal veins. This is a schematic which shows how this works. Veins in the abdomen converge into the large portal vein, which then feeds into the liver, shown here, and then it exits through the hepatic veins. And MPN patients are well known to have a propensity to have clots in these kinds of veins. So there can be portal vein thrombosis or hepatic vein thrombosis, which is also known as the Budd-Chiari syndrome, or thrombosis of the smaller veins, which we refer to as splanchnic veins. The reason for this propensity for intra-abdominal venous thrombosis in MPNs is not clear, but I should note that some fundamental studies done by Dr. Ron Hoffman and his group and then others have shown very interestingly that the endothelial cells of these intra-abdominal veins in MPN patients actually carry the V617F mutation, just as blood cells carry them. So presumably there is something that carriage imparts on the endothelial cells that makes them more coagulable. Now, in terms of arterial thrombosis, we talk about large arterial clots, including arteries that thrombose in the extremities, leading to limb ischemia, and very importantly, cerebrovascular arterial thrombosis, which can lead to strokes when there is an infarction or when there is a partial occlusion or transient occlusion of the arteries, a transient ischemic attack. Ultimately, multiple large infarcts in any patient could lead to what is called multi-infarct dementia later in life. Now, we also know that in addition to venous and arterial thrombosis, there is thrombosis of the microvasculature. One of these involves the placental circulation in pregnant women who have underlying MPNs. These are women who mostly have essential thrombocythemia, who as a result of this develop ischemia of the placenta, an actual placental insufficiency, often in the first trimester, which can lead to poor fetal outcomes, including growth retardation, and in extreme cases, even fetal death in the form of spontaneous miscarriages in some women with essential thrombocythemia. And then there are cases of digital ischemia where occlusions occur in the very small vessels that connect the arteries and veins in the extremities, for example, in the toes and fingertips. And the prototype of this is something called erythromelalgia, which was described well over 100 years ago in a PV patient, but has since been seen in other diseases other than MPNs. Now, erythromelalgia involves the development of extreme pain in the dependent parts of the body, particularly the feet, and especially on the soles of the feet, as shown in this picture, where the excruciating pain is actually corresponding to areas that are visible on the feet of erythema, as you can see here, this patch of erythema, which is also very warm to palpation and extremely tender. These forms of erythromelalgia, in most cases, respond very well to aspirin. And if you did a biopsy of one of these areas of erythromelalgia, you would see the small vessel being totally occluded by hyaline in this case, which most likely represents a platelet plug. Now, what about bleeding complications in the MPNs? So for unclear reasons, at least unclear to me, these complications are less common today than when the MPNs were first described. In fact, essential thrombocythemia was originally called hemorrhagic thrombocythemia, as you can see from the title of this article from 1956. Nevertheless, serious and even fatal bleeding complications still do occur in some MPN patients. So what is the mechanism for this? Well, first of all, even though the platelets in MPN patients may be increased in number, they are also defective in function. So in some patients with MPNs, platelets may not be able to execute their main responsibility of normally plugging gaps in the vasculature and thereby stopping bleeding. But probably the most important reason for the bleeding propensity in most patients with MPNs is this, and it involves a protein called von Willebrand factor, which is a huge protein that circulates in our own plasma, which serves the purpose of being a sort of a circulating glue, if you wish, which helps platelets to stick to injured vessel walls and to prevent bleeding. There are individuals who are born with this inherited defect, and they have von Willebrand's disease, but patients with MPNs can have what we call acquired von Willebrand's disease, where these large molecular weight multimers shown on this gel electrophoresis of different sizes of molecular weights, these large molecular weight multimers, which are the hemostatically most effective portion of the VWF molecule, are missing in these MPN patients who have acquired von Willebrand's disease. And therefore, they develop a clinical bleeding tendency. In terms of the relationships between high blood cell counts and thrombosis in our patients, in the case of erythrocytosis in P. vera patients, there is a clear relationship between the risk of thrombosis and increasing hematocrits or red cell counts. However, and this is the reason why we target hematocrits in P. vera patients to less than 45%, because the risk of bleeding anything above 45% increases incrementally and even exponentially. But this can't be the only reason for clotting in P. vera, because there are non-MPN patients who have diseases like chronic obstructive lung disease, or healthy individuals who live at very high altitude and are therefore hypoxic, who operate at hematocrits of as high as the 70s or mid-70s, and yet have no clinical thrombotic events. So in addition to the viscosity, increased viscosity caused by a high hematocrit in a P. vera, there must be other factors that are prothrombotic. In terms of leukocytosis, it has been thought that there is a likely relationship to thrombosis risk that's been reported in several articles that tended to use single time points for blood counts. More recently, this has been questioned using a method called trajectory modeling, which analyzes multiple white blood counts longitudinally at regular intervals of up to 48 months in each MPN patient, reflecting what has been called cumulative exposure to leukocytosis. And when this kind of analysis is done, there has been no correlation found between thrombotic risk and this cumulative exposure to leukocytosis. Now, in the case of platelet counts, I think there is common agreement that there is very poor or perhaps no relationship at all between the level of platelet count in thrombocytosis and the risk of a first thrombotic episode. And in fact, in extreme thrombocytosis, those individuals may in fact be at a counterintuitively bleeding risk rather than a thrombotic risk. What we know now is that there is a major player involved in these thrombotic complications, which is inflammation. And how this works in a very oversimplified way is that the mutant NPN stem cells in the microenvironment of the bone marrow secrete pro-inflammatory cytokines, which initially cause an inflammatory state locally, but which becomes systemic eventually. And the inflammatory state that's caused by this works to aid MPN clonal evolution. The inflammatory response actually promotes selectively the mutant, let's say JAK2 V617F mutated MPN clone at the expense of normal stem cells. So this would lead to even more MPN stem cells being produced preferentially, which would then lead to release of more pro-inflammatory cytokines, more inflammation, and so forth, in what we think is a vicious cycle. I think nobody will argue with the fact that the driver mutations in the MPNs that arise in the hematopoietic stem cells are the primary trigger for initiating clotting and for initiating these diseases. But undoubtedly, inflammation, if not the boss, then is certainly very culpable as an accomplice in this cycle. And with inflammation, what happens is that all the blood cells in the circulation, red cells, white cells, and platelets, which are already activated by their intrinsic mutations, like JAK2, are further activated by the inflammatory state that they encounter, which the MPN cells have created. And the same may be true for the endothelial cells, which are the inner lining of blood vessels. So this creates a very prothrombotic milieu within the circulation and the vessel wall that contains it. Now, in the last couple of minutes, I'd like to say a few things about a recently identified topic, which many of you may not know about, but which I think will become a major focus of research in the MPNs in the near future, and specifically research into the thrombotic problems of the MPNs. And this is the phenomenon of clonal hematopoiesis of indeterminate potential. Now, since this term doesn't exactly roll off the tongue so easily to pronounce, clever investigators in the MPN field have used the acronym CHIP, which I think we should all use from here on for this phenomenon. It turns out that with the advent of next generation gene sequencing, which are proliferating among the population, it's been discovered that mutations in certain genes occur during one's lifetime spontaneously without causing any disease, and probably in most cases without ever causing disease. And for some reason, these mutations that pop up as a function of aging are not entirely random. They tend to occur more frequently in genes that have been implicated in hematologic malignancies, including, of course, the JAK2 mutation in the MPNs shown here. When they pop up in the circulation, they have a very low allele frequency, and they're not accompanied by any blood abnormalities. And as I mentioned, this is very much age-related, so CHIPs are found in the circulation in less than 1% of those below the age of 40, found in about 10 to 14% of persons aged 71 to 80, and in more than 16% of people who are older than 80. And this has led to the feeling, the consideration, that CHIP is simply a part of the normal aging process as the human genome becomes more fragile. This schematic shows this more dramatically. This is from 3 different studies shown in different colors, which shows the relationship of CHIP frequency with increasing age, which becomes almost exponential in the later years. Now, there is a minor risk that some of these CHIPs will turn into problems. And it is estimated that the annual risk of transformation of a CHIP into clinically diagnosed MPNs or another hematologic neoplasm is about 0.1 to 0.5% per year It's a very low frequency. But despite this very low rate of chip progression to MPNs or other myeloid malignancies, it was found that people who carry these chips, regardless of their age, have a significantly higher overall mortality rate than those who don't. So the question comes up, why is that the case if they're not developing MPNs? And in short, having a chip is an important problem by itself. In one prospective cohort study of people, unselected individuals who never had clinical heart disease, persons who had chip mutations in the DNMT3A, the TET2, or the ASXL1 genes had a 1.7 to 2 times the risk of developing incident coronary artery disease. And persons with chip mutations in the JAK2 gene, the JAK2 V617F particularly, carried a 12.1 times the risk of developing coronary artery disease. So what we're saying in summary is this. We have known, mostly indirectly and certainly through experimental animals, that MPN patients are at significantly increased risk of atherosclerotic cardiovascular disease. But now there's the recent recognition of JAK2 V617F mutant clonal hematopoiesis, or CHIPS, in people with no overt MPNs. And this chip actually carries with it a 12-fold increased risk of atherosclerotic cardiovascular disease than in those who do not have that chip. This will lead to very important questions about what are the implications of this finding, not only for atherosclerotic cardiovascular disease prevention, but also for MPN patients who develop arterial thrombosis or are prone to developing arterial thrombosis, since, as I mentioned earlier, that develops almost exclusively on a substrate of atherosclerotic cardiovascular disease. So this is my final slide, and it summarizes the scheme that we think is operative. We do know for sure that MPNs are a major risk factor for thrombosis. We know that inflammation, which is caused by MPNs, can actually aid and actually enhance the thrombotic risk. The thrombosis that occurs could be either arterial or venous. The ones that are arterial almost always occur on underlying atherosclerosis. And we know that chip mutations, which are very prevalent as one ages, can actually eventually, in a very small minority of people, lead to clinical MPNs, and they can certainly lead, even in their chip state, to enhanced risk of developing atherosclerosis. So I think this is a very rapidly evolving area. We're finding more and more about the early stages of MPNs and pre-MPN states, which may be the chips, and their ramifications for arterial and venous thrombosis. Thank you.